Welcome to A Conversation with History. I'm Harry Kreisler of the Institute of International Studies. Our guest today is George C. Halvorson, who is Chairman and Chief Executive Officer of Kaiser Foundation Health Plan and Company and Kaiser Foundation Hospitals. He's the author of numerous books. His most recent one, Healthcare Will Not Reform Itself. Mr. Halvorson, welcome to our program.
Good to be here.
Where were you born and raised?
I was actually born in northern Minnesota, raised in a very small town up in the backwoods. My parents were both from that same town, so I come from a very small town. My father and grandfather were mayors of the town. My mother was deputy mayor. They were all school teachers, so I come from a teaching family in rural Minnesota.
And looking back, how do you think your parents shaped your thinking about the world?
Well, the fact that we lived in a very small community meant we knew everyone. And the fact that my parents both did small-town political office, being mayor, for example, for my father and grandfather, meant that they had a sense of accountability. They believed that if we lived in the town, we should do something to make the town better. So my grandfather was working in the nursing home. My father was working on the city park and the streets. And so I always had a sense that you ought to have a sense of accountability to the community you're in. But I think that actually probably shaped my thinking quite a bit.
One gets a sense that state in that part of the country has a real cooperative spirit,
yes,
based in cooperatives and the Scandinavian origins of many of the people who settled there.
Yes, we were co-op members. The co-op Sampo store was a block from our house. The cooperative culture, the culture of collaboration, was a big part of the community. And again, cooperative governance of the gas station, the grocery store, the hardware store was all part of what I grew up with. So later years, actually, Health Partners is the largest healthcare co-op in the world. And so I actually went from being in a town with co-op stores to running a healthcare co-op.
And how did you?
And I found it very comfortable. I loved running a healthcare co-op.
And what was the trajectory here? What did your education impact your choice of career, or was it just kind of a natural evolution based on this environment that you grew up in? Well,
I sort of accidentally got into healthcare. I was in communications, and I saw a job opportunity for an underwriter, and at the Blue Cross plan, and I thought underwriter meant assistant writer. So I applied for the job. After they got over being amused about it, they hired me to a different job, which was actually a writing job. But then they trained me as an underwriter. And I went through the underwriting training and kind of fell in love with the business. I fell in love with the thought process and the thinking involved and the numerical interactions, and ended up as an underwriter for a Blue Cross plan. And then I evolved from that into doing provider contracting and setting up their network of care providers. And then I evolved from that to running a health plan that they started, one of the first network HMOs in the country. And I've been a CEO of one health plan or another since 1976. So I've been doing this for a very long time.
Which raises an interesting question, which is, students watch this program, and I always like to pursue the question, what are the skills involved in leadership in the health field?
I think the health leadership isn't that much different than other fields. What you need to have is I think, really good sense of what your organization is all about. Why does it exist? What's it here for? And if it's here to make a profit, then you've got one agenda. If it's here to provide service, you have another agenda. But I don't think you really do a good job, you don't succeed really well leading an organization, running an organization, unless you have a clear sense of what you want the organization to do. And then as a leader, you need to help get other people aligned with that agenda. You need to recruit the right people, you need to promote the right people, you need to help people figure out strategies and plans and operational processes. And in healthcare, healthcare is about taking care of people. The essence of healthcare is that you have a patient. You know, healthcare kind of boils down to the patient, and so you need to figure out what do we do as an organization that's going to make life better for each person who becomes our patient. So you need the whole team to think like that. So it's not just, that shouldn't just be on your mission statement. You need to have all of the people who work there in their heart know that what this organization is about is taking care of the people. And if you teach that, preach that, model that, then you're much more likely to have an organization that works and does the right kinds of things.
And the field of healthcare is one where there seems to be a tension between what value will prevail. What I have in mind here is, on the one hand, it's about caring, it's about the big philosophical issues, life and death, providing the care for people who might not be able to pay, and so on. But on the other hand, in our present environment, we're really concerned about cost and keeping medical costs down. Is that a tension that comes up a lot, or is it easier to reconcile those two things than seems apparent in the first instance?
Well, I think the people who believe that there's an inherent conflict there are missing the point of what the opportunities are. We have an incredible opportunity in this country to make care better, a lot better, and by making care better, make it less expensive. So right now, diabetics consume 32% of the cost of Medicare, which is a big piece of Medicare. Mm-hmm. It's the fastest growing disease in America. We only get care right for diabetics 8% of the time in America. So if you look at how often we get care right, and the fact it's 32% of the cost of care, if we got care right for diabetics 80% of the time, we'd cut the number of kidney failures in America in half. Would cut the number of amputations in half. I mean, there's huge opportunity, but the opportunity isn't to ration care to diabetics. That would be stupid. The opportunity is to get care right for diabetics and make sure we deliver best care, and as a result of that, we don't need to do amputations, we don't need to do the eye surgeries that result from inadequate care. So there's huge opportunity. The other thing on diabetes, talking about that for a second, is there's a great opportunity to go upstream. It's the fastest growing disease in America. If people walk 30 minutes a day, 4 days a week, the number of new diabetics would be cut in half. If they lose 20 pounds on top of that, the number of new diabetics goes down by 60%. Mm-hmm. So the fastest growing disease, the largest single use of money for Medicare, we could cut the number of new diabetics in half by 60% just by walking and losing a little weight. And we don't have right now, as a country, a macro agenda that's aimed at that. And we should. This is inappropriate for us. I think it's a missed opportunity for us not to identify a few of these really high leverage opportunities, and then to take steps as a country to move in those directions.
What is it in a leadership role that leads organizations and systems not to see these opportunities? I think this is in part a question about creativity, and it's also, but it also seems to be related, which is a theme that comes out in your work, about embracing technologies and the opportunities that they present.
Yeah, there's two sets of issues. One set of issues is the business model of American healthcare is set up to reward exactly the wrong things. So the business model of healthcare does not reward keeping seniors from having broken bones, because every single senior with a broken bone is a $40,000 hospital admission and a lot of profit. And if you prevent the senior from breaking a bone, you get nothing for it. Same thing is true in asthma attacks. We should be able to prevent half the asthma attacks. There is no reward for an independent provider to prevent asthma attacks. There's no reason for hospitals to be involved in preventing asthma attacks. Even the worst case is hospital-based infections. A patient that's a $20,000 admission that gets a horrible infection in the hospital now becomes a $100,000 admission. If the world were right, that would be a penalized situation, and instead, it's financially rewarded. There's no hospital in America that would ever, ever, ever damage a patient or do anything to get a patient to have an infection. But the fact that there is absolutely no upside, most hospitals, if you took away their readmissions and you took away the bad outcomes in their readmissions, would actually find themselves financially challenged. And think about that for a second. Think how bizarre that is. So the financial model is set up to reward exactly the wrong thing. And what we wanted to do is reward health. We wanted to reward best care. We wanted to reward having fewer complications, and you can get there. So, and then the second part of the equation is, why doesn't healthcare use computers when everything else in the economy uses computers? Every other part of the economy is heavily computer-based, and healthcare has almost no computerized data relative to care. And the reason for that is there is no business model that rewards that for most of healthcare. Most of healthcare, again, if you computerize the model of care, if you identify people at high risk of breaking bones, if you follow up on their care and track their care, make sure they have fewer broken bones, what you end up with is the surgeons have fewer surgeries to do, the hospitals have fewer admissions. Putting that computer system in and making care better cuts their revenue. So why would they? Name one other business that computerized to damage their financial condition. You can't find one.
Now there seem to be two problems here. One is that the insights that you're having, and this is true in your books, which I highly recommend because they really lay out some of these problems in great detail, is to have these insights. You really have a systemic view of the enterprise. And I guess what one runs up against and one wonders about is what American healthcare is built on is the individual practice.
In pieces.
And in pieces. And you call that, your analysis shows that what we're talking about is a system built on piecemeal work, the individual practice. You point out that only 4% of physicians in the United States are in practices with a team of 50 doctors and so on. So there is a systemic way of seeing things, which quantitative analysis and would help us see the issues in part, and computers will help us solve those issues. But you're trying to put that on an environment which is built on the individual doctor, the individual patient, and their very human concerns about their work and their own treatment.
Well, even the world that we live in with all the individual doctors, those doctors have no connections right now. 80% of the care comes from people with chronic conditions and comorbidities. And comorbidities means multiple conditions, and that means in this country more than one doctor. And right now, there are no linkages. The doctors, all these solos, private doctors, can't link with each other. They have no mechanisms, no tools, no forms, no processes, no computer systems. And in fact, if they try to link, in some cases, they run up against HIPAA violations, and they end up with being in violation of the privacy and secrecy laws. And so what we've done is we've taken this piecemeal, segmented, solo practice environment where everybody practices in a little bitty silo, dealing only with incidents of care, and then we put processes in place to keep communication from happening, which is bizarre. And then we set the system up so that if anybody does do a better job, they make less money. And in any other industry, if you went to Mercedes and said, every time your car gets better, we're going to reduce the amount of money you get. And if your car gets really good, we're going to take away your 50% of your revenue. Mercedes would never get better as a car. I mean, this isn't hard. I mean, you just have to apply the basic principles of economics to healthcare and realize that if doctors were rewarded for functioning in teams, teams would happen. If they were rewarded for having fewer heart attacks would happen. But when you're only rewarded for having more heart attacks, we have an increasing number of heart attacks. I mean, this isn't very complicated when you boil it down to the essence. And people keep saying, why don't computers improve healthcare? Well, computers wouldn't improve any other industry either if the consequence of using a computer was that your profits went away and you lost patients and you lost customers.
I guess what I'm hearing here is a problem of education, that the route that we could take to reform medicine and healthcare is very clear. And there's real resistance. And is it because people are irrational, they're afraid, they're emotionally involved in their own health care, and they don't want to make these changes?
I don't think that would be the way I would interpret it. I think everyone is totally emotionally involved in their own health care. That's true. And I also believe that if people could make meaningful decisions about where to have your heart surgery, or where to have your knee surgery, or where to go for your cancer treatment. I mean, the life expectancy varies so much between cancer treatment programs that for stage 3 pancreatic cancer, or better choice, prostate cancer, you get 3 times as many survivors at 5 years if you go to the best institutions compared to the worst. Consumers would want to know that. If you had prostate cancer, you would want to know who has what survival rates. And consumers would make those. The reason consumers don't make those decisions now is they don't have the data. The data is not available. Consumers can't make that decision. Your chance of dying of a CABG, of coronary artery bypass surgery, varies by a factor of almost 10. The best sites have about a 1% death rate, and the worst sites have about almost a 10% death rate. Consumers should know that before you have that surgery. Consumers would want to know that. Consumers aren't resisting making smart decisions for emotional reasons. They're resisting making smart decisions because nobody's giving them the data. So what we need is a new marketplace that is heavily informed by real data. We need to know the survival rate statistics. Think of one person you've ever known who's had stage 3 pancreatic cancer, and the doctor said, here's your 2 treatment programs. In this one, you'll live 6 months. This one, you'll live 7 months. That database isn't shared with the patient. And so patients are making uninformed decisions in a wide range of areas. But I don't blame it on the patient. I blame it on the fact that we've set up an economic model that doesn't give anybody any data to use to make good decisions.
So what you're arguing, if I can restate it here, especially in your books, which I recommend. I showed one of them, but let me show another one, Healthcare Reform Now, which lays out an agenda for the United States in this environment that we have, that technology allows us to have control of data in a new way.
Yes.
And that combination of data and technology to make that data available to patients, to doctors, and to epidemiologists who are studying the statistics would empower us to kind of re-engineer the environment of healthcare and transform the system.
Exactly. And we can't transform it without data. If you don't know, I'll give you an example, sepsis. Sepsis is an infection that is often fatal. Right now, it's the #1 cause of death in California hospitals. So more people die of sepsis than die of cancer or liver disease or heart problems. And so sepsis is a major problem. And most hospitals don't know what their sepsis death rate is. They don't track it, they don't use it. The patients have no clue. And when you take a look at sepsis, you know that it's 2% of the patients and 20% of the deaths. So for starters. So the question is, what can you do about the 20% of the deaths? And if you have the data, then you can work backward from the data and say, we're going to identify sepsis patients faster. When you look at sepsis, the magic in sepsis is, to get a little tiny bit technical, is a very quick response. You have a golden hour, and you need to respond within that hour. And in most hospital settings, somebody thinks a patient might have sepsis. They try to run a blood test. They may or may not get a priority on the blood test. If they don't get a priority, the patient is in big trouble. If they do get priority in the blood test, then they run back to the floor and they say, yeah, it's sepsis. And then they say, okay, anybody here ready to deal with sepsis? And there may or may not be a doctor. There may or may not be a nurse available. There may or may not be any of the supplies. So then they say, okay, we quickly need some medication. Can anybody get it? And then they run down to the pharmacy. And then you've got this circus going on for, okay, quick, let's get the sepsis stuff up there. Then we get up 4 or 3. And if you miss that hour, then the death rate is doubled. And if you do it right, you've got a process that says sepsis, this could be sepsis. That test gets top priority, goes right to the lab, gets immediate priority. They get the response back and they say, yeah, it's sepsis. And then they say, push the button, and sepsis response team, room 427, and the team is in the room with the medication, with the supplies. And with that, that kind of team, we've cut the death rate on sepsis by 2/3 for the hospitals who put that in. So 2/3 cutting the death rate. Okay, patients don't even know that what sepsis is going on, and we could not have cut that death rate if we hadn't measured it, tracked it, thought it through, worked at it systematically, set goals, and so the key to the process is to figure out what you want to fix, measure that, and then track your improvement, and then put processes in place to fix it. That all takes process thinking. Most hospitals have very minimal process thinking. Most hospitals in America reinvent, I write about it in my books, I write about reinvent shift change at every shift change. Every floor of the hospital has different procedures for things. They have different
So when the nurses
backups.
are leaving at the end of their duty, there has to be a changing of the guard.
Exactly, and so what you need is you need the nurse who's leaving to tell the new nurse, here's the patient, here's Sally. Sally needs these 3 things. You need a process to do that. And it usually takes about 40 minutes per shift, front and back, to do the change.
So one nurse is telling the other nurse, watch this patient for such and such.
Right. Okay. And what happens is, because it's usually done orally with a little bit of paperwork, what happens is that it's just like, remember the old game you play in the classroom where you whisper something to somebody in the front row, and then it goes to the next one, next one, next one, next one? Well, that happens on shift change. So by the time you've done 12 shift changes, which is, basically 3 days of care, you've ended up with misinformation about patients. Don Berwick wrote a magnificent book where he talked about his wife being in the hospital, and he basically had 2 of the best hospitals in America made at least 1 error every day. And most of those errors were shift change kinds of errors, a person getting the medication wrong. So what you need to, but again, it's very simple. If you know that, then what you can do is you can say, let's standardize that. Let's have a common approach. Let's ask the same questions. Let's have the same document. Let's have the same piece of paper. Let's make sure that the shift change happens the same floor to floor, shift to shift, and that it happens the same at midnight as it does at 8 in the morning. And when you do that, then you get a whole different level of care quality. The information, the quality of the information goes way up, and you cut the amount of time necessary to do it in half. But because most of American healthcare, as I write about in my books, is so local, so situational, and so invented on the spot, there's no systemness to it. And so people don't look at issues like errors at shift change. They don't look at errors like wrong site surgery. They don't look at sepsis responses. And so it's like the chaos you see on the TV shows, on the ER shows, the constant chaos. What's really pathetic is that's actually fairly accurate. I mean, you end up with this kind of, in way too many settings, not everywhere, but way too many settings, you end up with that kind of a situational chaos is the mode of delivering care. And everybody gets the adrenaline rush, and everybody, people who do that think that's the way the world ought to work and are immersed in it. And that's what, but when you fix it, people like the fix and tend to go with a better approach. So if we went back to our nurses and said at shift change, why don't you just do it any way you want, and kind of invent it on the fly. 2 years ago they would have said, yeah, that's the way it works. Today they'd say, no, I would feel insecure now changing shift without making sure I had all of the information, all of the medications, all of the instructions, all of the guidelines. And then, so process can improve in healthcare, but it so seldom does, which is one of the things that drives me absolutely crazy. Which is why I go back again to the issue of rationing. People keep saying we got to ration care in America. No, we don't need to ration care. We need to get care right. Let's go there first.
You earlier in your career, you were involved in building healthcare cooperatives in Uganda, and you wrote a book about it, a fascinating book. Let me show our audience, Healthcare Co-ops in Uganda. And you said something in there that I want to read to you back. I believe that the skills set needed to keep a United States contracted care network thriving is pretty much the same skill set needed to start a brand new healthcare provider network in a developing country. So on the one hand, conceptually, there are common elements in how we improve the system. But then you go on to say, and I'm not saying these contradict each other, these two statements, but rather they inform each other. One-size solutions do not fit all countries. I had learned quickly not to assume that all American solutions worked everywhere. Right. Local problems needed local solutions. So rather than simply applying American solutions to Uganda, we focused entirely on what was actually needed in Uganda. Now, what I find interesting is that we can take this analysis and really apply it to American healthcare today, in the sense that you're arguing that there are common elements of process and common opportunities that would allow us to actually deal with the local conditions in a way, right? That's really the challenge. But I guess the problem in my mind is to really change things. You almost need a revolution, because you always push up against the resistance from the piecemeal nature of the system. The individual doctor who basically does not have electronic records of his patients, who basically wants to make decisions for the patient that are inconsistent with the opportunities that technology would bring. That's a problem, isn't it?
Well, it is a problem, but one of the things I've learned, I actually started health plans in Jamaica, I started health plans in Santiago, Chile, helped do health plans in Spain, and then I did health plans in Uganda and helped to plan and get started in Nigeria. So I've worked in a number of countries, and one of the things I've learned is that you can't just take the American template and its entirety, drop it in anywhere and think it'll work. That's foolish. The model doesn't work. You can't take, when the number one issue in America is something to do with lengths of stay in the hospital, and you go to a third world country where there's no hospital, clearly that solution set isn't going to transfer. But what does transfer is a sense that we need to focus on the patient, we need to focus on team care, we need to make sure that the patient gets care that's based on medical best practices and algorithms. And so what does transfer is the science of medicine, but a lot of the process infrastructure and some of the financial parts don't transfer. When we got to Uganda, we had to run that health plan for 10 cents a month administrative cost. I think about that. I mean, a dime a month. We said, what do we have to do to get down to a dime a month? Could we transplant an American Blue Cross system into Uganda and run it for a dime a month? And the answer was no. So what do we have to do? You have to boil the health plan down to the essence. So you get rid of claims, and what you have instead is you have a physician and a hospital who are prepaid for a package of services. So nobody fails. I mean, claims processing is just an incredible waste of time, effort, and money, because you spend all your time filling in all this information. You send it to somebody else, they spend all kinds of time working on it, then they send it back to somebody else, you go through the accounting. You get this piece of paper flowing back and forth 3 times to generate a check for a piece of care. And that's irrelevant to the whole process of actually delivering care. So in Uganda, we took these little co-ops, we collected milk and tea leaves and coffee beans and whatever the premium was, and we turned that directly into care by going to the local caregiver, collectively purchasing a package of care. So we eliminate all the administrative costs relative to claims, completely wiped them out. We wiped out all of the membership and billing by having the collection be in that form, and what we had for each family was one ID card for the entire family. There was a photograph of the family that we embossed, and we put the healthcare information on one side and the family picture on the other. And so the family would take it with them. So we eliminated paperwork, we eliminated bills, we eliminated claims, and we actually ran it for $0.10 a month. So then the question is, by getting it down to the essence, so then the question is, what does that teach us here? So if we come back to the US, where we've got an administrative cost that is just massively higher, what can we think about? How do we get US down to $0.10 a month? So one of the things we're doing at Kaiser Permanente is we're actually trying to emulate that Uganda model by going entirely paperless, by having electronic medical record, by having electronic billing, electronic enrollment, having every single thing connected electronically, so we can eliminate all those layers of non-value adding expense relative to processing all the pieces. And we're on our way. We actually have now 26 of our hospitals were recognized last year for being paperless. And
I'm sorry, say? For
being paperless.
Yeah.
The HIMSS people recognized 26 Kaiser hospitals as being among the top 36 most paperless hospitals in America. But that's actually an extension of the learning from those little villages in Uganda where we set up the co-ops, because we said in Uganda, how do we eliminate every non-essential thing but still do the essential things? And same thing is true. If Kaiser Permanente can become entirely paperless, then we can change our administrative infrastructure and have the resources focused on care delivery and not on processing claims.
So it seems that we should take a moment to talk a little about Kaiser, because Kaiser has become this extraordinary petri dish, shall we say, for testing new possibilities that technology offers.
Yes.
And let's talk about the uniqueness of that system, because across the board, paperless, data at the fingertips of the patient, emails between doctor and patient,
right.
Doctors, before you were talking about the lack of connection between doctors, you go in for a hip transplant and the doctor doesn't know, I should say a hip replacement, the doctor doesn't know that you're on certain heart medication, but all now going paperless, interconnectivity, that is all at the fingertips of the patient and the doctor. And then in addition, I guess you're creating this extraordinary data bank of information which can track the systemic causes of ailments, whether medication. Talk a little about that.
Yeah, one of the things we just did in that regard, we now have 10 million electronic medical records. So we have the largest electronic medical record in the world, and it's completely interactive. It's real time. So the doctors have all the information about all the patients all the time. So when you're in the room with your doctor, that information flow is pretty complete, and you can email your doctor, and we've set up connectivity. When I was just traveling a short while ago, I had my medical record in my pocket. I had a little insert and just put it in there, and so it was just a very nice process. And the reason we can do that is because we are vertically integrated, because we have all of the pieces. Kaiser isn't split into little pieces. So we have hospitals, we have clinics, we have labs, we have pharmacies. All of the pieces are part of KP, and the really nice thing for us to be a microcosm is that we have prepayment. So you pay a premium to Kaiser as a Kaiser member, and then we get to take the premium and figure out how to do the right things with it. And the rest of the world, and broken bones we cut broken bones by 47%. We did that because we had prepayment from our members, and we figured out who's at high risk of breaking bones, and we put care plans in the computer for those people, and then every single nurse doctor who interacts with them interacts in the context of that care plan. And we've actually had a huge cut in broken bones, and 25% of the people over 70 get a broken bone die within a year. So they're actually improving the death rate, it's improving everything. But we saved a lot of money. We saved about $60 million by doing that. And for anybody else, that would have been $60 million loss in revenue. And for us, because we're prepaid, there was no loss of revenue. For us, it was just better care, and if anything, it was a reduction in expense. And that's a very different model. And I often say that we're bigger than 42 states and 140 countries. And so we think like, and we have all of the care components, so we think like a country. We have ministers of health from other countries come to Kaiser all the time. We've had the Minister of Health in my office in the last year from Germany, Ireland, Switzerland, Netherlands. Minister Klinke from the Netherlands has been here a couple of times. We have a whole series of interactions with the other countries. We're bigger than Norway, so we've spent time with the Minister of Health from Norway. We have an exchange program with some care sites in Sweden. And so what we're doing is we're learning from those folks, and they're learning from us. And they think like us. They think, because we have accountability for total population, as they do, and then we've got a total budget because our total revenue comes in. We don't make more revenue by doing more transplants. We make more money by getting care right and having better outcomes. So, and the fact that we're not-for-profit is also very nice, because not-for-profit means I don't have to go to Wall Street every month and explain to a bunch of stock analysts what we're going to do to maximize our quarterly revenue. If we miss our quarterly revenue, everybody knows it because we were public about it. But so what? I mean, stock prices don't go down. You know, nobody's investment portfolio is diminished, and so. So
you're in a way free from the market, but you're using market ideals, a market that's been directed by insight, so to speak, to increase efficiency.
Yeah, we're free from the stock market, but we are totally involved in the care market and the insurance market. Mm-hmm. So we're selling premiums side by side against Blue Cross Blue Shield, Aetna, WellPoint, Cigna. So we compete with those guys all the time. And so patients make choices, members make choices. So we have to have a better price, better product, better outcome than they do to survive. Muhammad Yunus talks about social businesses. Mm-hmm. He says there's two kinds of businesses in the world, the kind that are built around a profit and the kind that are built around a mission. They're both totally legitimate as businesses.
I'm sorry, the second
built around a mission?
Yeah.
So Yunus just wrote another wonderful book, mm-hmm. and the book is about social businesses and the nature and construction of social businesses. And he basically says a social business, because the Grameen banks that he set up are social businesses. He's now done some eye hospitals as social businesses. And the whole concept of social business is it functions as a business, competes in the world with other businesses, and the purpose of it is to achieve whatever its mission is, loans to poor women, whatever. And we're sort of like that. We're a social business, and we're about delivering health care to our members. And I love the fact that I do not have to go to Wall Street and fight for my stock price. You sit in the meetings, and when you look at the law, the number one accountability of somebody who basically has stockholders, there's a fiduciary responsibility to the stockholders. And what I have is an ethical accountability to our members, but the stock prices don't float around based on whether or not we have done something. So we can invest. Kaiser Permanente, we invested $4 billion in electronic medical record. And $4 billion is a lot of money. And we made that investment without flinching because we knew care would be better on the back end of that. And if you were a different company out there in a for-profit world and you had to go back to the Wall Street analysts and say, and here's exactly what our profit margin is going to do based on that investment, it would have been a tougher investment.
How do you account for the emergence of Kaiser, the Mayo Clinic, Cleveland? There's similarities with the models. Mm-hmm. It's sort of so different from the way the American medical system has evolved. So I guess there are two questions. One is, how do you explain Kaiser's emergence on the one hand, and then what are the lessons that you can actually implement for the broader American system? Because I think it's very clear, even in your own writings, that tomorrow we're not going to wake up and the whole country is going to be Kaiser.
All right. Oh, the Kaisers, Mayo, Cleveland Clinic, Geisinger, there's half a dozen large medical groups in the country where the physicians all practice together, multi-specialty. They have absolutely no downside. If you are at Mayo and you refer to a colleague inside Mayo, that doesn't affect your income in any way. You don't lose a surgery, you don't lose. Most places, the doctor makes a referral and loses a surgery. That changes the amount of money they have to pay their kids' tuition in college. Okay? At Mayo, it's no impact. So Mayo is built around best care. Mayo is built around the patient. Mayo is built around a culture of doctors who are collaborative and collegial, and doctors select into that. Mayo is salaried physicians. Kaiser Permanente salaried physicians, Cleveland Clinic salaried physicians, Geisinger salaried physicians. There's another, in addition to being multi-specialty groups, these are groups that have chosen a compensation model where they want the doctors to make every single decision based on the best interest of the patient and make no decisions based on their personal income. They want to decouple personal income from the decisions. That's a very elegant and clean model. And most of American healthcare is built around, if a doctor turns somebody down for surgery, that's $6,000 they're not going to get. Well, how many surgeries do you not see done? I mean, we see same thing on scans. At each of those settings, the scanning team is submerged into the overall structure. In the rest of the world, every scanning unit's a profit center, and they do as many scans as they can do, and they do whether people need them or not. And the fact that a scan is equivalent of 1,000 x-rays doesn't get mentioned to people who are getting the scan. I mean, if I said, would you go in and have 1,000 x-rays this year and then have another 1,000 x-rays next year and 1,000 x-rays, you'd say, George, you're kidding. Mm-hmm. And then people come to you and say, you know what, you should have a scan, and then you need a baseline scan, you should have a follow-up scan, and they don't tell you about the 1,000 x-ray thing. So in a system like Mayo, they know that. They know exact radiation count. They know exactly what it's about. They keep track of the accumulated radiation count for their patients over time because they're about the patient, not about the billing opportunity.
What are the systems that are in place to continually monitor accountability? The accountability that I think comes from bureaucracy and human error. When you think of a group process, you know, your immediate fear might be, well, this is going to be a bureaucracy. I'm not going to have the hands-on of the, you know, the skilled professional and so on. What are the mechanisms there? And then there's always human error to correct the system.
You mean in those groups? Or
yeah, in the groups, anyway. Yeah.
Well, yeah, the mechanism in the groups is, first of all, there's a selection process to get into the groups. I mean, most provider networks, anybody who raises their hand has a license and signs the papers in. Mm-hmm. And if you go to Mayo or you go to KP, we probably have 8 candidates now for every available job in most of our areas. And so we go through a screening process. People are interviewed, and so we pick people who we think have the right skill set, the right culture, the right disposition, want to work in a team environment. Because some people don't want to work in a team environment. Some people just want to be solo people, and that's fine, but they should be solo people. But other people want to be in a team, and they want to be part of a team. So what we do is we go through a selection process, and then we go through a screening process, and then we make sure that if there are outliers or people are not performing, or if there are problems, that they're dealt with. And so the top priority is patient. We need to make sure the patients are getting the right care. And so there is an internal feedback loop as well. And then there's increasing amount, which is really good, of external quality tracking. And so we're now beginning to, you can now find out the coronary artery bypass surgery mortality rate in hospitals. 10 years ago, nobody had a clue. Even the hospitals didn't know. And now there are ways of finding it out. It's not easy. You can't find it out in a hurry. You certainly can't find it out when you're on the operating table and trying to figure out where to go for your surgery, but it's now available, which is a huge step forward. Because we can look at that data. We can sit down, again, as a care team, as a care system, we can look at our data now and we can say, here's where we are, and that compares to these guys, and that compares to these guys, and if these guys are doing better than we are, why? What's that all about? You don't know that. When we first started measuring infection rates in our hospitals, every single hospital basically passed a test of knowing the right thing to do. And we saw a variation that was quite startling to us, actually. But there's some hospitals were the very best, and some hospitals were down bottom third. And so what we've done is we've moved everybody up. So now, 3 years after we started that program, the worst hospital is better than the best was when we started. And there's actually a chart on that in my most recent book, showing that progression. But the thing that was fascinating is the people who had the lowest dot on that chart, the hospital that had the lowest dot, absolutely believed they were doing a great job. They were completely, they would have passed any lie detector test you would have given them, and they would have passed, because they believed they were doing all the right stuff, they knew the right stuff, and then when they found out they weren't necessarily doing all the right stuff, and there was an inconsistency, and some other people weren't, they didn't know. And it wasn't until it became a process point and a data point, and they started measuring and following up, that they learned, and then once they learned, then they could fix it. But you can't fix something you're not aware of. And you can't aspire to something if you don't know what's possible. So the data points are really important. And so going forward, part of your question, going forward, we need to identify the data points that are the most relevant data points for American healthcare. And some of those should be cancer survival rates. We should have that data available to us, because people with cancer should be able to make those choices. And some of the data should be about heart surgery survival rates. And some of the data should be about the percentage of patients with diabetes whose kidneys fail. I mean, we should be looking at the outcomes, and based on the outcomes, letting patients make meaningful choices. And then we also need to get as much team-based payment as we can. So the kind of model that the Kaiser has, where we get a capitation, we get a prepaid amount, is a really good model for team care, because the money can come out of the team. In fact, I'll tell you a horrible story, and it's actually, I don't remember which of the two books it's in, but a city in the southern U.S., some very smart people working with the community clinics decided to create team care, and they did it using a computer model. So they set up an exchange, a computer registry for all of their patients who were very poor, who had diabetes and congestive heart failure and coronary artery disease. And they put care plans for those patients in the computer. And then every time those patients came in, no matter which doctor saw them, because they had a rotation of doctors, these are clinics for poor people, and some of the doctors volunteers, some were permanent, but they had a rotation. But no matter who saw the patient, they had the data about the patient, they knew the care plan for the patient, and they could interact with the care plan. They cut the number of hospital admissions for those patients in 6 months by 73%. They cut by literally, I mean, so they had a huge improvement in quality of care. And do you know what happened to that program? The hospital that was hosting it killed it. And they killed it because they needed those admissions. When you cut your admissions by 73% and your entire revenue stream is based on, so they actually killed the program that was providing the best care in town because they needed the admissions.
So what, look, if the country cannot become like Kaiser, how do we move in that direction? I think you believe that there are real possibilities in a kind of cyber integration. Right. Talk a little about that.
Well, it was a little bit like the thing I just talked about.
Yeah.
I mean, what those folks did was a form of cyber integration.
Yeah.
They weren't vertically integrated like Kaiser, but what they did do was they did identify for patients who had multiple health conditions a mechanism so that each of the doctors dealing with them had all of the information. You can do that electronically. You have to have a discipline about it. You have to actually have the data. You have to have someone maintain the data. But it's all doable. So you can take all of these solo doctors in America and you can actually get them to work together in teams if there's a mechanism. But every team has to have a structure and a captain. You got to have somebody, a primary care doctor, somewhere in there who's looking at all of the work in this patients and make sure there's a plan in there, care plan. And then you need to have everybody else in the team interacting with that database. But if you do that, even outside, we do it naturally because we have all the data in our electronic medical record, and all of our patients have primary care doctor. But you can do that in a non-Kaiser setting. And a couple of community clinics have proven you can do that. Denver Health has done some of that work in Denver for, again, in their case, for the poorest population. So I truly believe there is a cyber Kaiser or a virtual Kaiser that should be created in just about every place you've got patients with comorbidities. And I think what people can do is learn from what we're doing, because the stuff that we're doing is working. So we're cutting the number of broken bones, we're cutting the number of kidney failures, we're cutting the number of whatever. And the fact that we're having success should encourage other people to go there. But then what you have to have is you have to have something in the business model that gets people there. So then you have to have the employers in a given community saying to their health plans, we're only going to use you if you have team care. And if they say we're only going to use you if you have team care, then they put team care in place, and team care has its own benefits and its own positive outcome. So you don't need to put every single doctor on an incentive plan. What you have to do is you have to have teams that exist and function and are supported. But you could do that. If employers wanted to do that, major employers in a given community wanted to say, we want our doctors all to be doing teamwork for our diabetics, our congestive heart failure patients, they could mandate that their health plans come up with a connecting mechanism, and they could do that.
After reading your books, I went back and looked at a summary at what was passed under Obama's legislation that finally got through. What grade do you give that legislation in the context of what we've been talking about, the Kaiser model, in the context of the importance of interconnectivity, in the context of re-engineering the environment to create a market in which there are incentives to do good care? How do you...
I think what I keep saying is that healthcare reform in America has to have three pieces. And the first piece has to be coverage reform. We've got to get the insurance reform right. We're the only country in the world that doesn't cover, industrialized country, that doesn't cover all of its citizens. And so
you have to do that.
So we need to do that. That's foundational. We've got to do it. We've got to do it. You can't fix when only 47% of the kids with asthma are getting right care. One of the reasons for that is there are all kinds of kids who have no coverage. But if every kid in America has coverage, then you can fix asthma care. So what I always say is first coverage, second care, and we need to get the care agenda lined up. We have to have fewer patients dying of sepsis. We have to have fewer kids with asthma. We have to pick some major issues and fix that, and we can fix that. And then the third agenda is cost, and cost is third, not second. If you try to put cost higher, then you start doing things about rationing, or then it's about paying differently or something, and it's a different world. But if you say, we're going to fix care, and then because we have half as many hospital admissions, we're going to have less cost on that side, that's the right model. So it's coverage, care, cost. In the bill that was passed, points us down a path toward coverage. It actually has many provisions that tee up the care. So the trick is now going to be in the execution. It's going to be how well the Secretary Sebelius take the 270 shalls that she has in the bill. Secretary shall do this, Secretary shall do that. There's about 270 of them. And the Secretary shall track hospital infection rates. The Secretary shall have exchanges that have, the Secretary shall make sure that the computer systems connect with each other. There's a whole bunch of shalls in that bill. The shalls weren't discussed much in the debate, but they're there. If you go through and read the bill, the next couple of years are going to be about the shalls that weren't even talked about on the debate. And so we're going to see a world where the proof is going to be in how well we execute against the shalls. We should be able to make a lot of progress. The progress isn't guaranteed, it's not inherent, it's not slam dunk, but it is teed up, and so the secretary has a bunch of powers and the ability to convene people that and to move collectively in a good direction. So it's going to be a performance issue at this point. And if the secretary does the kinds of things that I think are possible, and I think Secretary Sebelius wants to go in those directions. I think she is directionally correct on those topics, and I think she's trying to figure out right now. And I frankly was personally extremely encouraged when they picked Don Berwick to be the head of CMS. Mm-hmm. Because if you think about, you could have picked a politician to be head of CMS, you could have picked an administrator, you could have picked a bureaucrat.
CMS is?
I'm sorry, Medicare and Medicaid.
Oh, okay, good.
To run Medicare and Medicaid, yeah.
Okay.
So the Medicare and Medicaid programs report to CMS along with CHIP, the children's program. And so there's huge, CHIP, the CMS buys for more care, twice as much care as the British National Health Service. I mean, it's a huge purchaser of care in America.
40%, I think, right?
Yeah, exactly. It's a huge, it's massive. And so the CMS job is a really big job, and we have never used it in this country in any way to improve the quality of care. Some small stuff, but nothing significant, nothing major. And so when you look at who runs CMS, you can put in a bureaucrat, you can put in somebody who's a lot of political skills so they can lobby Congress, whatever. And what they did was they reached out to the head of IHI, which is the Institute for Healthcare Improvement, Don Berwick, who is a Harvard physician who has been the quality guru in America for a number of years. And Don, about 10 years ago, started a program called 100,000 Lives. And he basically said if hospitals did these couple of things, they could save 100,000 lives next year. And he went around himself and he proselytized and he managed to persuade enough hospitals to sign up, and they saved more than 100,000 lives. And so Don has this track record of quality improvement in healthcare. So when they picked Don to run CMS, and his background is to quality improvement in healthcare, that to me is very encouraging.
One final question, we're running out of time, so a brief answer. What lessons do you think students should draw from your career and the life experiences we've discussed that might influence them if they're interested in working in the healthcare field? Any simple lessons?
Find something that you love to do. To the extent, my father used to say, if you have a job you love, you never work a day in your life.
That's good.
So find something that you really like doing, that you want to wake up in the morning and go do, and to the extent you can do that. That's not always possible. And that's one thing. Second thing is be open to new approaches, new avenues. I never would have gotten to Uganda had I said that doesn't make any sense for where we are. But look for adventures in your career. Look for learning opportunities and learn every day to the extent you can. Be in a perpetual learning mode, because there's always people who can teach you things, and there's always things you can learn from every setting. And so learn, enjoy learning, and learn every day.
On that note, Mr. Halvorson, I want to thank you for being here. I want to show your book again because I think it's a very readable statement of where we need to go in healthcare, and you really tell us what the title says: healthcare will not reform itself. I want to thank you very much for giving us this opportunity to have you here. Thank you.
Thank you.
And thank you very much for joining us for this conversation with history.